Welcome, everyone. This is Sophia Aasha from the Reproductive Health Supplies Coalition, we will be getting started in a few minutes. So we appreciate your waiting patiently as we let a few more people join the webinar. And hello, this is Sophia again from the RHSC. We do have some folks continuing to join, so please hang on for a couple more minutes and we will get started. So welcome. Again, this is Sophia Aasha from the Reproductive Health Supplies Coalition. We welcome you to this webinar for the Safe Abortion Supplies Workstream of the NERT Caucus. We appreciate your joining us today as we will be walking through the results from a recent landscape assessment that was conducted. A little bit of housekeeping. Everyone is muted to allow for a smooth presentation. However, please know that you can raise your hand when you have questions. And also, there is an opportunity to enter questions in the question box. We will have a significant amount of time for a robust Q&A period following the slide presentation. So we'll look forward to hearing from many of you then. And I will now hand off to my colleague, Brian McKenna, for a brief introduction.
Thanks, Sophia. A warm welcome to everybody to our webinar today. So with the support of the Children's Investment Fund Foundation, CIF, and a large anonymous donor, the Coalition is implementing a project entitled Leveraging the Role of National Distributors to Accelerate Access to Medical Abortion Combi-packs in Sub-Saharan Africa. The first phase of this project entailed a landscape analysis for which Mann Global Health was commissioned. Today's presentation, given by Chastain Mann and Aasha of Mann Global Health, will run us through their findings, the conclusions, and recommendations. So we're looking forward to a good presentation and a good discussion following. So with that, I will turn it over to Chastain.
Good morning, everyone. Afternoon, evening. Next slide, please. So as part of the landscape, we had to look at a number of different countries and narrow the list of countries in sub-Saharan Africa down to a manageable number in a very short period of time. So given the timing constraints and budget constraints, we could only visit on the ground 4 countries. Those 4 countries were Burkina, Senegal, Uganda, and Zambia. another 4 countries, we did quite a few remote interviews with stakeholders and a lot of back and forth, but remotely. Those were Ethiopia, Mali, Malawi, and Sierra Leone. And then for 2 countries, Mozambique and Zimbabwe, we could only do kind of a brief literature review and sort of a brief pass at looking at the environments in those 2 countries. Next slide, please. So the way we selected the countries that we selected was really subjective, of course, but we looked at a handful of different criteria. The legal status of abortion in the country, the environment, the political climate and the environment for abortion, the current registration and availability status of all MA products, not just Combi-packs, but misoprostol as well, the potential for scale and ease of doing business, the availability of national abortion data and research, any contacts or relationships that we could leverage with commercial distributors, and the potential for regional representation. Next slide, please. So why did we pick the deep dive countries that we picked, and what was interesting about them and made them stand in as archetypes for other countries? Well, for Burkina, there was a relatively restrictive abortion law, but there have been positive changes in the last year or so, and DKT has introduced a Combi-pack very recently. In Senegal, we would not normally have chosen Senegal, but we chose it because it is such a difficult environment. Highly restrictive abortion laws, some of the most restrictive on the continent, and highly developed regulation and oversight. Zambia, on the other hand, had one of the most liberal abortion laws, and there are several Combi-packs that have been registered and are being sold there. However, there are some policies and guidelines around prescriptions that really are choking off women's access to medical abortion. And in Uganda, you've got very good commercial distributors with great kind of international standards, but the Combi-pack sales by the SMOs, the social marketing organizations there, have only started in the last year or so and are still going pretty slowly. Next slide, please. So in general, the categories that we looked at for the landscape assessment were the enabling environment, market dynamics, and the perspectives of commercial actors. So the enabling environment, as we included in the list we showed a couple of slides earlier, was the legal status, the policies and regulations that affect abortion provision, the registration status for abortion products, levels of commitment and attitudes towards abortion, and then the practical implications of existing policies and regulations. For market dynamics, we looked at the current availability of products and what might be in the pipeline. So there are a number of products that the social marketers are attempting to register that are sort of in the works, and so we were very curious about those as well. And then for the commercial actors, this is really a lot of the focus of what the RHSC project with SIF and the large anonymous donor is looking at, is how can we boost the inputs of the commercial sector in the overall market for medical abortion and Combi-packs in particular. So we talked to a range of commercial actors, importers, wholesalers, distributors, pharmacists, and we looked at a bunch of different market interventions to gauge their willingness and interest in joining that market. Next slide. So I'm going to turn it over to Aasha to summarize the key findings, and when she's done with the key findings, I'll talk a little bit about some recommendations, and then we can move from there into discussion. Aasha.
Thank you, Chastain. I'll just start with a few words on terminology. We met with a range of different commercial actors during the assessment, importers, wholesalers, and distributors. And most of the ones we met were larger companies that actually were doing multiple functions and described themselves mainly as wholesalers/distributors. But for ease in our report, and as we go through this presentation, we're just going to refer to them as commercial distributors or just distributors, and we'll discuss some of the distinctions in a minute. But now I'll go on to some of the key findings. So we found that commercial distributors are willing to induce stock and distribute medical abortion, and the majority of them make a small profit doing so. You can see in the product availability chart that misoprostol is available in all the countries that we assessed. Combi-pack is available in 6 of the countries, and 5 of those countries actually have more than one Combi-pack registered. And the reason it works for these commercial distributors to distribute MA is that mainly they're working through social marketing organizations. And what they're doing is simply adding MA drugs to a host of other products that they're supplying. They're selling hundreds, even thousands of products. But their role in supplying the medical abortion drugs is a largely passive one. They're making it available, but they're not really doing anything to push it or to grow sales. So we call them distributors, but in fact, they're really acting more as wholesalers. The social marketing organizations are doing the work to sell Combi-packs in almost all the cases that we found. Next slide. So this is a map showing the presence of MA and the social marketing organizations. The SMOs in all the countries we assessed are distributing MISO and or Combi-packs. MISO is also being sold commercially without SMO involvement in all the countries, but only 2 countries, Zambia and Sierra Leone, have commercial distributors that are distributing Combi-packs without any involvement of SMOs. So as I said before, largely this distribution of the Combi-packs is happening through a partnership between SMOs and commercial distributors. It was the SMOs that induced these distributors to start distribution of Combi-packs, and it's the commercial distribution that allows the SMOs to deepen their sales reach. Next slide. Distributors that we interviewed are not willing to invest in demand creation for medical abortion. Instead, they really look to the SMOs for this kind of support. And in fact, every distributor we interviewed cited product detailing and promotion for MA products as absolutely necessary to create demand and also to provide them with cover. It's expected that brand owners drive sales, and many of the distributors we met had sales reps from brand owners of different products embedded in their businesses. And this is especially important for a more complex and controversial product like Combi-packs, which opposed to misoprostol are only used for abortion. So for example, the distributor in Sierra Leone told us where we really need them, the SMOs, is talking directly to the providers. They're the ones who can persuade them to use the products and teach them how to work. And in Zambia, a distributor told us that Mary Stopes was giving very detailed education to the pharmacists so they know how to assist the clients. And this decreases the risks of anything going wrong, like different types of complication. And this gives the commercial distributors some type of protection, knowing that this is happening, as there's still considerable stigma and fear felt by the providers, even in a place like Zambia where the law is relatively liberal. Next slide. So findings on price. Price from the manufacturer is not a major issue that we found in improving the MA market. And in fact, the cost of a Combi-pack usually runs about $3 to $5 US. For the client, MA is not purchased for routine or very frequent use. So this is an important consideration when thinking about price. It's a product that's purchased only when needed. Combi-pack prices for most markets compare favorably to the other abortion options, such as surgical, MVA, or even traditional methods. We found prices mostly at $5 to $10 US. But of course, with this, there's variation, as you'll see in the next slide. Next slide, please. Thank you. So in this slide, if you look to the second to last column, we're looking at the price range to the client. This slide traces through, how much Combi-packs are being bought from the manufacturer and then what they're sold onto to the distributors and then onto retailers and then to the client. So again, mostly we're finding $5 to $10 being sold to the client, but this can vary up to $100. So this would be, at the high end. This could be, for example, in Zambia, where pharmacists are selling up to $100 to sell to women without a prescription, which is actually required. Or another example is in Ethiopia, where you have a smaller number of high-end clinics that would be selling Combi-pack at this price. And then at the lower end, the very low end, you might have something like $5, $6, $5, for example, in Ethiopia at a lower end clinic. The point of this slide is really also to show that along the value chain, there have to be profit margins that are made. And so we've shown some examples here. And what we saw typically was that there were profit margins being made at around 20 to 30%, which is considered to be a low margin. 20 to 30% made by the distributor selling onto the retailer. And then at the retailer level, you see more variation coming in. Next slide. An interesting finding, commercial brands of Combi-packs will not necessarily be more expensive than social marketing brands. For example, in Zambia, the commercial brand price is actually the same as the Marie Stopes Marie Prist price, which is 12 to 15 US dollars. However, of course, commercial actors aren't motivated to ensure affordable prices as SMOs are. And so there's no guarantee that prices would remain affordable in the longer run. And of course, this is just one example. Next slide. One of the obstacles to greater commercial market activity in MA is the cost of market entry. Distributors see the time required for product registration as an important barrier. The cost at around 5,000 US, that's probably the highest we heard, they're seen as less of a barrier. It's really more the time taken to prepare dossiers, knocking on doors until you get approval. That's more of an issue, especially when registrations could take up to 1 to 2 years. And distributors are generally not willing to do this for a new, relatively low margin product, especially if it's a more controversial product such as Combi-pack MA. Next slide. The major risk cited is the level of minimal orders and the high possibility of expiring stock in this context of relatively low demand. Minimum orders can be as much as 30,000 doses, and misoprostol's shelf life is only 2 years. And we heard quite a few examples of stock expiring in different countries. Next slide. Social marketing organizations have made really good headway in some of these MA markets in getting products registered, detailing and training providers and retailers, and of course advocating for wider access to MA for women. So as I said, it's really this work that's induced the various commercial companies to start distributing MA and to continue to distribute it. Next slide. But there remains a question as to whether commercial actors need to continue to rely on social marketing organizations as, quote, middlemen, when markets are maturing and a higher level of demand has been created. Given the wide distribution channels for pharmaceutical products that distributors develop and maintain, adding an MA product is feasible if the entry barriers can be reduced. The question then becomes what happens to the MA market if commercial distributors are incentivized to enter or to work in MA without SMOs. Interventions, of course, should grow the market and not fragment it, and equity has to be considered. There's a risk of cannibalizing the sales of the social marketing organizations and undermining their ability to be sustainable, certainly where a lot of markets are now, where sales are low. In some markets, however, it may make sense for SMOs to phase out or to focus more on demand generation rather than on sales. So now I'll pass over to Chastain for a discussion of some of our key recommendations.
Thank you. Next slide. So an overarching recommendation that we have is based on the fact that in all of these markets that we went and looked at, there's little kind of cohesion and coordination in the markets at all. Governments are not typically playing much of a stewardship role in these markets because it is a controversial product in a number of places, actually all of the places that we went to. And so one of our recommendations is that RHSC, as part of this project, could play this nice kind of neutral facilitation and stewardship role where you bring the different market actors to the table and you talk about what's going to make sense for improving the total market and not just any one market actor's position in that market. Next slide. So we have a number of other recommendations that are a little bit more specific. One is that in some places where there is no market or very little market for Combi-packs at the moment, that you look at registering some new commercial Combi-pack products. In Malawi and Zimbabwe, for instance, there are no Combi-packs, but there is commercial capacity. And so in a place like that, you would probably consider registering and distributing through the commercial actors. In other places, there are no Combi-packs, but there is NGO and social marketing organization capacity. So you would work through the SMOs, but then distribute through the commercial actors. And these would be places like Mali and Senegal. Then finally, a category of where social marketing organizations have registered Combi-packs and they're available, but there's additional commercial capacity for increased sales. You would want to register and distribute more through those commercial actors. So start graduating that market more towards commercial sustainability. And those places would be places like Burkina, Uganda, Sierra Leone, and Mozambique. Next slide, please. So Aasha mentioned this point of the risk of having too much stock on hand and not having enough demand, and then you've sunk an investment into all this stock that then expires and has to be destroyed. So one of the things we recommend looking at is assisting with the negotiation with the manufacturers to have a gradual release of stock in sync with that demand. Another possibility would be to pool procurement across different countries. Next slide, please. So for markets that are in somewhat better shape, a little bit more advanced, you want to go in and think about building those markets. So in those terms, we would recommend that donors pick one or more of the locally based commercial companies and incentivize them in the short term to perform different market functions that aren't working very well currently. These could be functions around demand, medical detailing. They could be other kinds of functions working on the supply chain. But in those markets where the market is a little bit more established, we do see this opportunity for greater commercial capacity and involvement. Next slide. So there's a lot of question about the role of social marketing organizations, and I'm glad to see that we've got a number of social marketing people on the phone. At the end of this presentation, which is in just a moment, we'd love to have you guys weigh in and ask questions or offer up opinions. We did speak with all the social marketers, and it's really quite interesting. So they're doing some wonderful work, as Aasha said. They're working quite closely with commercial distributors in many of the places we looked at. So we wanted to look at what the sort of smart, short to medium to long-term goals should be with regard to the social marketing organizations. So the first point, do fund social marketing organizations to do the community education and awareness. Nobody's doing that very well, if not for NGOs and social marketing. Commercial guys don't really do that. So that is a great role for them. Do fund social marketing to do medical detailing. Or another option is medical detailing in-house in those commercial companies. You could fund some of that, or a combination of both. There are places where social marketing organizations second somebody to a commercial company to do that medical detailing, and that seems to be a model that works well as well. This is the third one, is the controversial one. Don't fund long-term social marketing, urban sales and distribution and their associated overhead. When you go beyond the short and medium term, you really need to be looking more towards commercial sustainability. It depends on the status of medical abortion markets in each of those countries. But for the longer term, you do want to graduate to where social marketing organizations are doing the things that the commercial guys will not do. The final point here is do fund social marketing organizations to reach rural and vulnerable populations. If you want a market to grow, if you want greater equity in the market, somebody needs to focus on those populations that are not likely to be highly profitable. Next slide, please. So policy change is obviously something we have all given a lot of thought to over the years, and a number of organizations are doing a lot of work on that. You want to liberalize laws and remove barriers that prevent access to safe medical abortion. The Zambia case was an interesting one where, despite a relatively liberal abortion law, the policy is that you need prescriptions from 3 clinicians in order to access medical abortion. Places like that, you really want to work on policy change. Next slide, please. So in Uganda and Zambia, where the markets are relatively more advanced than in other places, you'd want to expand rural access and redirect subsidies away from urban areas to underserved populations, so rural populations and women who are otherwise not being reached. Put more funding into provider promotion and behavior change in these rural areas, and put more funding into awareness raising in the communities. The social marketing organizations and NGOs are best placed to do this kind of work. As I said earlier, the commercial sector guys it's not really a profit-making kind of endeavor for them, so they're not going to be the ones to do it. So in those areas, you really do want to work more on equity and reaching populations who need to be reached. Next slide. So that's it for us. We have appreciated all the contacts we had with DKT, with PSI. Marie Stopes was a partner with us, as was WCG Cares. We would love to hear from all of you, and hope that it's a very long report, but only because it's a separate report for each country that we submitted as part of the overall package. But we welcome your comments, and we thank you all for the assistance you gave us in doing this. Back to you, Sophia.
Thanks, Chastain. I'm just going to chime in here really quickly, and just before we go to questions, give you and Aasha a big thank you from the coalition. We asked you to do a mountain of work in an extremely short time, and you guys pulled it off with class and have really put together an amazing report that not only the coalition appreciates, but the community appreciates. So thank you very much. And with that, I'll turn it over to Sophia, who will monitor our questions and answers.
Great. Thank you, Brian. And I, of course, echo Brian's thanks to the team. And we know that, as Chastain mentioned, we know that the team was composed not only of Mann Global Health, but of very valuable partners, including Marie Stopes International and WCG Cares. So as we kick off the Q&A period, we'd like to first give an opportunity to the partners who worked with Mann Global Health on this landscape assessment. So if there's anyone from, say, MSI or WCG Cares or any of the other partners who participated in the landscaping, please feel very free to raise your hand and or enter questions, and we'll be happy to call on you. And at this time, we haven't seen anyone signal that they would like the floor. Oh, it looks like Wilberto.
Hello.
So, Ellen, would you like to go ahead, please, with your question or comment?
Thank you. Thank you so much for the opportunity to work with everybody here. I think the one point I would say, it's all about knowing where the tipping point is. And what I mean by the tipping point is getting the demand built, getting the awareness built, and getting enough critical mass of volume moving through the system so that the commercial actors, as you call them, you know, it becomes actually a really positive kind of model. And I think the challenge that we have with Combi-packs is that firstly, most providers find it quite challenging to move from misoprostol to a Combi-pack, and that's because of the associated issues around that in terms of understanding the legal situation in country. So it's quite a challenge to build that awareness that it is a legal product, it can be used, and it's also an expensive challenge in making sure that the provider themselves knows exactly how to dispense that product properly, and also provide a continuum of care for the woman should there be complications. So I think the critical thing to take out on this is where the markets will change and they will evolve, but we need to understand the tipping points, and it would be a very dangerous thing to do, to pull investment out before that has been created. So that's really the point I wanted to make. It's an opportunity for women in many markets, but unfortunately it's not being realized today because of some of those challenges.
Thank you, Helen, for that comment. And Chastain, is there anything that you would like to add?
I agree completely, Helen, and I think that's the challenge. And I think that we did kind of a cursory, given the time constraints, kind of a cursory look at the countries that that we were focused on. Our recommendation would be before you make any move in a market, you spend a lot more time getting to know what's going on in that market than just a kind of overarching landscape assessment. I agree with you that there is a tipping point, and knowing when that tipping point is on the horizon is critical. So one of the first rules, to my mind, of any sort of market intervention is to really know your market before you start tinkering with it. So yes, I agree.
Great. And Helen, I can also add from the perspective of the Reproductive Health Supplies Coalition that we certainly now as the landscape assessment is complete, we are not rushing into planning and conducting market interventions, but rather really thinking thoughtfully, deliberately about the strategies that would make sense, and including others in those conversations. So now we can go ahead to the next question or comment. And it appears that John Townsend entered a question. And we will unmute John so that he can speak.
Okay, hello, thanks Chastain and colleagues. I wanted to know a little bit what happens to the offer of MVA, vacuum aspiration, in the country studied once medical abortion is introduced in the commercial sector. In the United States, I understand that MVA is now accounts for about 40% to 30 to 40% of all procedures, and I'm wondering if the same thing happens to in developing countries, and what happens to those providers? Do they still remain active in the field? Do they go on to something else? I'd just be interested in your thoughts.
John, it's a good question, and it's not one I have an answer for. I think organizations like IPASS and others have looked at that much more closely, at what happens to MVA markets when medical abortion is available. It's not something we examined. We didn't look at a total abortion market, right? If you were to look at a total abortion market, you would look at MVA, you would look at traditional methods, you would look at all kinds of different methods, and not just the medical abortion methods that we look at. I imagine there are others on the phone who have more information about that, though, and who can answer it.
So we have a few more questions, so we'll continue on for now. And James Ayers has his hand raised. James, you can go ahead and please chime in with your question or comment.
Okay, thank you. Yeah, I just wanted to say that, PSI was really excited to read this report. We welcome it because it really echoes our philosophy that social marketing organizations really need to evolve as the market evolves. And so on that note, I wanted to ask, one of the recommendations was in more advanced markets, donors work with incentivize commercial distributors to do things that they wouldn't, functions that they wouldn't normally perform. And if I missed it, I apologize, but I wanted to ask, what was the definition of commercial in that sense? Does it also include social enterprises, or is it only strictly private sector firms? So that's one question. And then just kind of curious if other assessments are planned in the future, and if you guys have any, what are the plans for the taking these recommendations forward?
Thanks, James. So when we talk about commercial guys, the commercial actors in a market, if PSI directly or others so enterprise, to my mind, that's commercial as anything else, right? So I would see no problem with any of that. The idea is when we talk about boosting the role of commercial enterprises, whether a social enterprise or a strictly for-profit enterprise, the idea is that you then put donor money very specifically to the functions of the market and the goals that you want to get to in that market. So rather than continuing to fund social marketing kind of business as usual, looking to graduate that market a bit and increase the sustainability that comes with greater commercial involvement. If that involvement is a social enterprise and it's not just more money for social marketing as usual, then I think that's great. In terms of your question about what other landscapes or market assessments are planned, a couple of our colleagues on the phone, I believe, are from the Concept Foundation. Chai has done some of this work as well. So there are a number of different groups out there that have been looking at abortion markets and landscapes. And perhaps one of them would chime in. We did coordinate with all of them, and we are sharing notes amongst ourselves because some of them have gone deeper in certain countries while we covered others. And I'm sure that RHSC would be willing to kind of connect you with all those different organizations.
Thank you.
Thank you, James and Chastain, for that. As Chastain said, we certainly look to the coalition's role as the coordinating partner on this work, and the inputs of organizations like the Concept Foundation and Chai have been very useful, both for the landscape assessment as well as we expect to continue throughout the life of this project. Now, next, we see that we have Wilberto Robles with his hand raised. Wilberto?
Yes, can you hear me now? Hello?
We can.
Okay, perfect. So I just wanted to say, thanks, and we appreciate to collaborate in this report with Mann Global Health. And just wanted to highlight, after hearing John Thompson mentioning the MBA, there's a curious thing about this. As Aasha mentioned, abortion-related products are kind of tricky to register because of the stigma and other factors that can affect that. And different to MVA, this is a drug product. Therefore, having a proper landscape assessment in advance, kind of touching base with the regulators and other stakeholders in the countries, will definitely benefit the introduction, the successful introduction, and of Combi-packs in the future in new countries. And just wanted to leverage on that because it might not be seen as a struggle down the road, but it could represent a struggle because of the various stigma elements that you might not find in the regulations, but behind the scenes you can find that, and you can find other hurdles because of that. So just wanted to mention that briefly.
Thank you, Wilberto. And Chastain, did you have anything that you wanted to add to that?
Just to say that Wilberto is with WCG Cares, and he was our regulatory expert working with us on this landscape. So looking at the regulatory hurdles and kind of best practices, what's working, what's not working so well. So it was nice to have that expertise in thinking through how you might speed up and facilitate a process of product registration.
Thank you, Chastain. And we will continue as we do have additional questions and hands raised. And for those who will be called on, can you please, as you give your question or comment, can you kindly first introduce yourself and your organization? And I see that we have a question from Paul regarding how to maintain product quality standards. So Paul, you will be unmuted.
Hi, good afternoon or good evening, everybody. Yeah, it's Paul Screon from MSI here. My question is, have you thought about how to maintain product quality standards as you expand broader competition, given that there's only a limited number of certified manufacturers, either with WHO PQ or misoprostol or SRA and PICS? Have you thought about how that would be handled or stimulated? And have you made any comparisons with misoprostol, which has actually been commercialized quite extensively? Yeah, so that's my question.
Hi, Paul. So
Hi.
It's interesting. The question of quality assurance was one that we went in thinking we'd have a lot more findings around, but because and I would say right out of the gate that there's a sampling bias here on our part, because we worked with reputable commercial distributors, importers, and wholesalers who all kind of perform to something close to global standards. We really weren't finding issues of quality and big concerns about quality. Again, it's a sampling bias. If we were to look at the black market, which would be much harder to do, I think we'd have a lot more concerns. From the manufacturing standpoint, I think that one of the recommendations was to look at some pooled procurement, right? So if you've got a handful of countries in Francophone Africa, for instance, can you look at some pooled procurement to take care of some of those quality questions, as well as to mitigate risk of too much stock sitting unsold in any one place or another. Other than that, we have not gone very deep on the quality assurance questions. I think it's a legitimate question. And I think that, as you say, with a limited number of good qualified manufacturers, I think that there's a way that we can, get our heads around this so that we can pay attention to quality issues as we try and do some work across multiple markets at the same time.
Okay, thanks. The insight was really driven by some of our experience on misoprostol, where you see the leading manufacturers from Acme, who's WHO PQ, or Nari or Mylan, who are SRA, and you see high levels of stability and therefore low failure rate. You then see the broader market with no-name manufacturers, smuggled product, etc., where your failure rates are ranging between 25 and 40%, due to the instability of misoprostol. So given that misoprostol is a key element within the Combi-pack, I think it's just something that we need to think through before we seek to incentivize new competitors, rather establish the quality products to ensure that you increase the rate of adoption.
Thank you, Paul. And I can certainly say from the perspective of the RHSC that we definitely in moving forward on this project, the primary goals are not only to increase access through the commercial sector, but of course to increase access to quality assured products. Absolutely. Thank you for adding that very important point. And I see that Amanda Huber has her hand raised. Amanda?
Hi, my name is Amanda Huber. I'm from Population Services International. I'm currently in Mali, and so my first question is actually about the in the Mali recommendations, the recent article on mifepristone pretreatment for medical management of early pregnancy loss was cited as a reason to register a Combi-pack with an indication for pack, which I'm very intrigued by, but I don't know of any other. There's not really a body of work around that, and so I'm wondering if you have other sources that we could bring to the table in order to move that forward here in Mali.
So I'll turn that over to Aasha to answer that one.
Hi there. That was the only study that we came across. So I'm afraid there isn't a body of work we could refer to, but we thought that this could be a good starting place, and that would certainly have to be something that would have to be in any dossier to register a new product. And I'll also now pass over to my colleague who did the assessment for Francophone Africa, Angelica, who's on the line as well.
Oh, okay.
Hello, everybody. I hope you can hear me well. So it's a great, and the reason behind was that in the case of Mali, and also similar in Senegal, stakeholders were very clear that it seems quite difficult, or maybe even unlikely, to have a Combi-pack registered that has only the single indication for medical abortion. So that was a point that maybe having additional indications in the Combi-pack, such as the reference study that was mentioned in the case here, could maybe result in getting the product registered. But yes, as you said, there is much more work that needs to be done ahead of time. So we're at a very early stage in the reflection process in Mali. There's a bit more reflection into that going in the abortion task force in Senegal.
Okay. Okay, great. And I thank you. I just wanted to make sure there wasn't like more information out there that I wasn't aware of, because we would love to do that here in Mali, and it would definitely make it easier to register it for PAC. Also, I have a response to John Townsend about MVA. What we found in countries where PSI has registered misoprostol and trained providers in misoprostol for PAC and MVA, that providers still want to do MVA, and that many women still prefer MVA. I mean, it is a faster process, and that's what many women prefer, and it's definitely what many of our providers seem to prefer. So so we find that people are still doing plenty of MVA. Similarly, in India, where we are marketing Miso Combi-pack, we find that our providers also offer MVA. And indeed, if a woman comes in for post-abortion care, if she's taken Miso on her own and comes in for PAC, they almost always do an MVA. So so MVA still seems plenty popular.
Good. Thank you very much.
Sure. Okay, I'm done. Thank you.
Great. Thank you, Amanda, for your important contributions regarding both MVA and the perspective from Mali. Now, please know that there are several folks who do have their hands raised and or had entered a question. So we're continuing to call on you, trying to recognize you in the order that you raised your hands, and also in recognition of whether you might have already asked a question. So, Ntinda, would you like to go next?
Okay, good afternoon, evening, everyone. My name is Ntinda, and I'm with MSI based in Zambia. So my contribution, really, or rather question, was just around prescriptions as a barrier. So one of the key things, obviously, in Zambia is that you may have the product and you may generate some demand, and we have tested, some different demand creation strategies, but at the end of the day, the biggest challenge we have is actually getting that prescription to the client. So what I wanted to find out, is this unique to Zambia based on the overall study? And also, I just wanted to find out if this challenge is present in any of the other markets that you actually got a chance to visit, just so, if there's anything we could look at in terms of how that market's dealing with that, would be nice for us to know. So that's my only questions really around generating the prescriptions. Yeah.
So it's a great question. So Zambia was the one that really stood out to us, and the reason was that it was this weird mix of having good abortion laws, but really restrictive policies and regulations around prescriptions. So what we found, although it was kind of impossible to document, is that women are going in without the 3 prescriptions that they need and just paying more, up to $100 for a pharmacist to give them the product. So Zambia seemed like a real opportunity to go in and work on that particular policy and guideline to make it more in line with what the laws are. Did we find very restrictive barriers in other countries around prescriptions? Yes, but Zambia was the case that really stood out.
Okay, thank you.
Thank you, Ntinda. And next, Florence from the Concept Foundation.
Yes, hi, this is Florence from Concept Foundation. And well, first, thank you very much for this presentation, because it's, I think, a real gold mine of information for all of us here. And my question was especially linked to lessons learned on how you conduct the market assessment, if you have any recommendation and things that we wouldn't have things to look at in a market assessment, especially for the countries where you didn't go. And I guess you were working with the local consultant. Yeah, I just wanted to know if you had any recommendation on how to conduct this assessment. And my second question was, so you mentioned that for the minimum orders in the countries where you cannot reach one batch size, one recommendation was to have gradual release of stock. And I wanted to know if that's something that already happened in one country, and yeah, how did it happen?
Thanks, Florence. I'm going to let the second part of your question about gradual release of stock go to Aasha. I believe it was DKT that has negotiated that somewhere, but Aasha can answer that. As your first question, how to go about doing this type of market assessment when you have the resources to spend months on the ground, my main recommendation is to pick a partner like MSI in our case, who's got a footprint on the ground and is doing a lot of this kind of work, and is able to help you leverage their contacts and networks to have lots of phone calls with lots of different people. We also have some various tools that we use that we'd be happy to share with you for stakeholder interview guides and things like that. So there's no great secret to it, other than, to the extent you could get an MSI or DKT or PSI or some of the other to help you with the groundwork and the legwork in the field, it makes the job a whole lot easier.
Okay, yeah, that's great. Thank you.
Yeah, absolutely echo what Chastain said about the assistance that we got from MSI in particular, and from PSI and DKT. Wherever we went, the first thing we started with was going to the commercial distributors that they're using. And we also asked them, who did you approach before? Who maybe said no, so we could rule some out. So that was incredibly helpful, just making it much easier to start talking to people straight away. And then from there, another good tip was going to, in some countries, Zambia and Uganda had this. If you go to the websites, I know you know about the Zambia one, you can go and see the products that are registered. So we would look at and see which companies had registered or even selling misoprostol or other related products like pregnancy test kits or even emergency contraception, and then work off of that list. So that was another way that we got a lot of context that we got. But we'd be very happy to talk to you in more detail about this at any time.
Yes, with much pleasure. Yeah.
Okay, great. And then your second question about the minimum orders. The only place I found this was in Zambia. We found that a company called Yash Pharmaceuticals had previously had problems when they had ordered 50,000 doses of Combi and weren't able to sell them. So they've been able to lower their orders and negotiate getting a gradual release. And I think this is a really important thing. I mean, this really did come up everywhere, this fear around having expiring stock. So to know that that was an example was a good thing, and I think that that's something that definitely should be looked at. And really the key is just, you know, making sure that there's forecasting being done. This is something that MSI and other partners kept saying as well, that you've got to make sure you've got a handle on that, and going into those negotiations, what your sales are going to be, and keeping a close look at that throughout, so that your release is corresponding to what your sales actually are and expect them to be.
Yeah, totally. Okay, yeah, thank you.
All right, thank you, Florence. And moving along, Laura Fry.
Hi, this is Laura Fry from Genuity Health Projects, and I just wanted to go back to the earlier conversation that Amanda brought up about the other indications and how useful that might be for registration. Just to let you know that under the RHSC Innovation Grant, Genuity is currently working on looking at other indications of mifepristone, and so we'll be happy to share those results soon, hopefully at the general membership meeting. But we're specifically looking at the potential for labeling for cervical ripening missed abortion, IUFD, or second trimester abortion as means of expanding the market.
Thank you, Laura, for adding that. I know that the coalition and our members, just those of the Safe Abortion Supplies Workstream, are very much looking forward to seeing the results from the Innovation Fund project that Genuity is working on. Now I know that we just have a few minutes left, and we do have a couple of questioners remaining, including James Ayers. James?
Apologies, I didn't realize my hand was still up. I don't have another question. Sorry for that.
Okay, great. Then we can move back to Helen Black-Hawley.
Great, thank you. Yeah, a couple of points that have come up. Going back to the MVA point, decent, good quality counselling often ends up in a 50-50 split between MVA and MA in clinics. So I think that's an interesting perspective on choice. The other point that I really wanted to make is, if you are an SMO and you don't actually do the selling, and you're just providing the service provider, you know, you're just doing some of the detailing, that's basically just costs. So if you can't sell and recognize a revenue to offset those costs, then fundamentally what's required will be donor support to fund that detailing, which potentially in the long run is not a sustainable model. So I think that's one of the challenges that all of this and all of us have got to think about, is actually what does sustainability look like, so that the model, you know, a proper commercial model can actually thrive. So that was one of the other points I wanted to make. And I think we probably need to get a good handle on what boosting the commercial role really requires. And it goes back to the point that Chastain made, I think, around understanding what the triggers and the barriers are in order to be able to actually work against those specifically, and then work out who is the best organization to work against those. Most distributors stroke wholesalers have very little desire to work on those elements. They want to buy the boxes, they want to put them in their warehouse for as little time as possible and sell them to make their money. And the fact that so much of what we've also covered talks about expiry stock says either there isn't the demand there, or the order quantities are way too large. I suspect it's the latter, that the demand for the product on Combi is not there. They're just a few concluding thoughts. Thank you.
Thank you very much, Helen. And as we are at about time, it'd be good for us to go ahead and wrap up. Please know that any questions that are remaining or that you enter in these final moments, we will take note of, share with the presenters, and respond to you. So please do feel free to share any final questions. And even after the webinar, of course, you can always reach out to us if you may have questions regarding the landscape assessment. So we want to thank you very much for joining us today for this webinar. We hope that the slide presentation, as well as the Q&A period, was constructive and helpful to you in understanding this body of work and the potential going forward. So thank you, and thank you again very much to our presenters, Chastain and Aasha. We wish you a great rest of your day.